everyone. My name is Matthew Kurian. I'm a medical oncologist at St. Elizabeth's Cancer Center in Edgewood, Kentucky. Welcome to the Oncology Brothers event. I'm here joined by esteemed colleague. If you could introduce yourself.
My name is Giuseppe Curigliano. I work at the European Institute of Oncology, Milano, and University of Milano.
Perfect. So, well, thank you for joining us. And so let's dive into HER2 treatment a little bit as well, too. I know we've had a little bit of discussion. We'll start with the neoadjuvant setting exactly. Tell me exactly, when we're making decisions regarding neoadjuvant treatment within the community setting exactly, how do you make those decisions in terms of, for someone that, has a smaller tumor size, essentially a T1C, essentially, of whether or not to give them neoadjuvant chemotherapy? What are your decisions in making that?
But usually for small tumors, tumors less than 1 centimeter, you may also consider to do surgery first, and then you propose in the adjuvant setting the APT regimen. So you don't need, of course, to do in these small tumors a neoadjuvant treatment because the outcome is excellent.
Right.
With the APT regimen, with almost 98% surviving after 10 years of follow-up. When you move to PT1C, of course, usually I consider to propose a neoadjuvant treatment that can be also without anthracycline, but using the dual blockade. In the majority of those patients, you can achieve a pathological complete response, and then you can continue in the post-neoadjuvant setting, or with trastuzumab vedotin, or with trastuzumab and pertuzumab. So let's say that almost all of stage 1 disease can be cured. So this is the setting where to do a de-escalation.
Definitely. And then tell me about your approach for those that are greater than 2 centimeters and node positive. How do you make that distinction in terms of giving someone TCHP versus maybe a weekly train regimen or something similar to that? What goes into your decision making?
Now, in a stage 2 and 3, usually I consider for all the patients TCHP.
Okay.
Because the probability of pathological complete response and the probability of curing this patient population is so high that I would not prefer to reduce the intensity of chemotherapy. But if your question is, are you going to consider a regimen similar to APT in the neoadjuvant setting? Of course, yes. You can consider in the elderly population or in patients with smaller tumor and non-negative disease, where you can achieve exactly the same result without intensifying the chemotherapy regimen.
Definitely. And then tell me about your thought process in terms of triple positive tumors versus hormone receptor negative, HER2 positive tumors in terms of making that decision as well.
Oh, this is a very good point. I believe, of course, that in some patients with triple positive disease, maybe using some tests like HER2-DX, you can better tailor the treatment. I don't believe we have to discuss about escalation and de-escalation in this patient population. We have just to discuss about optimization.
Sure.
And personally, I believe that PCR, if you deliver a neoadjuvant treatment, should be the main point to achieve. And so use eventually tests like HER2-DX to better optimize treatment.
That's that. And then talk to me about post-surgery in terms of evaluating residual disease exactly. Do you have a size cutoff? What guides your decision-making in terms of using, TDM1 adjuvantly or not? Is there a certain size that you're looking at? Is it, discussion with all patients? How do you make that decision?
No, my decision is evidence-based. So in my opinion, any patient should receive a post-neoadjuvant TDM1 if you have a residual disease, even if 1-2 millimeters. Because if you check the subgroup analysis of the Catherine trial, it's very clear that also minimal residual disease can derive a benefit from TDM1. And another point that we should discuss is that also patients who were HER2 positive at the baseline and became HER2 negative on the residual disease derive benefit from TDM1. So personally, I would give TDM1 to any patient.
Any patient, okay. And then talk to me in terms of this year's SABCS exactly of some more novel strategies of in the triple positive combining, in the neoadjuvant setting CDK4/6 with AI and dual HER2, and then the addition of immunotherapy as well. Tell me a little bit about that space, or things that you think are exciting, or maybe things that we should be watching out for as community oncologists.
Okay, for sure was not exciting with is not practice changing, but the TOUCH trial evaluated the use of palbociclib plus letrozole plus pertuzumab trastuzumab versus paclitaxel, trastuzumab and pertuzumab in patients with triple positive disease. The primary endpoint was to validate the retinoblastoma signature or whether a retinoblastoma loss can predict resistance, but the trial failed on the primary endpoint, and as results, the rate of pathological complete response was very similar between the arm without chemotherapy, so with palbo, trastuzumab, and pertuzumab, versus paclitaxel, pertuzumab, and pertuzumab. It was 32% in the chemotherapy arm and 33% rate of pathological complete response in the arm with palbo and dual blockade.
Excellent. So now let's move on to the stage 4 setting and talk a little bit about metastatic disease a little bit as well. In the population of folks, especially within the community as well, and especially in the community where I practice in more rural areas, I see a lot of de novo stage 4 disease, exactly. Many patients presenting with brain mets initially as well, too. Talk about your approach to folks that are presenting with de novo metastatic disease, and particularly brain mets necessarily as well. What's your approach to those folks?
Actually, the standard of care is still pertuzumab, trastuzumab, and taxane. So my standard of care is the Cleopatra regimen. Outside the standard of care, I would consider, of course, to use trastuzumab deruxtecan. There is actually a trial ongoing in which also patients with baseline brain mets can be eligible if asymptomatic. So up to now, we use the Cleopatra regimen, but maybe in the future we can consider for sure TDX as a frontline treatment in these patients.
Definitely. And then talk to me a little bit about HER2 testing a little bit, within that setting as well, too. What are the challenges, I think, in terms of using, HER2 testing that may be a little bit heterogeneous, in terms of different distant disease sites as well, too?
But, ASCO-CAP can help you a lot on this because when they defined it, the ASCO-CAP was exactly designed in order to identify the minimum level of HER2 overexpression or eventually of amplification. You know that in the late edition of the ASCO-CAP, if you have an equivocal case in which it's not so clear if HER2 is amplified or not, it's up to the clinician to select. And so you assess eventually the level of heterogeneity, and if you believe this patient may derive benefit from an entire 2 strategy, I would go for sure with an entire 2 therapy. And this is what I do in my clinical practice.
Definitely. And then talking a little bit about second-line treatment, exactly, right? I think obviously a lot of people are using, TDXD, after the Cleopatra regimen. But talk about the next line of treatment after that as well. Where do people go? What sort of treatments do you personally, lean on typically in those that are brain met negative?
In HER2 positive disease after trastuzumab deruxtecan, my preferred choice is tucatinib, trastuzumab, and capecitabine. Because if you progress to an ADC, there is for sure a level of heterogeneity that you can address with a tyrosine kinase inhibitor, a chemotherapy, and an antibody. So my preferred choice is not an ADC, I mean TDM1, but is tucatinib, trastuzumab, and capecitabine.
Fair enough. Thanks again for joining us again for a fantastic session with Onc Brothers, and we hope to see you soon.